Welcome to my 6 months progress report. My PhD topic is investigating anterior cruciate ligament injury and reconstruction. I'm Robert Jonge from Uzsoki Street Hospital. My vision is to understand the nature of sports injuries, provide better care and life quality for knee-injured patients, as well as to further grow the merit of my workplace and the Semmelweis University. We could achieve this through resolving disagreement and controversies of anterior cruciate ligament injury and therapy. I have 2 ongoing projects. First project is comparing the conservative and reconstructive treatment of ACL tears. The second one is adding an lateral extra-articular tenodesis to the reconstruction surgery. So the first project, reconstruction versus conservative treatment. Anterior cruciate ligament injury is one of the most common sports injuries in Hungary. Before the COVID pandemic, we were doing more than 3,500 reconstruction a year in Hungary. The rupture of the ACL leads to instability, which is a prognostic factor for early onset osteoarthritis. The gold standard treatment is surgical reconstruction because of its associated improvements in knee stability, and conservative treatment serves as an alternative. However, with a good rehabilitative treatment, dynamic stability could be regained, as well as it eliminates surgical complications. So despite this is one of the most studied topics in orthopedics, we still do not understand which option could be better to prevent osteoarthritis, and our aim is to find out this. We are investigating ACL reconstructed patients, comparing them to conservatively treated ones, focusing on radiological and functional signs. We have made a systematic search, got more than 13,000 articles, of which only 6 made it to our meta-analysis. So as the results, first one is Radiological Signs of Osteoarthritis. On the picture, this is the Kellgren-Lawrence grading showed. On every grading, there is a clear cutoff value between healthy and knees that are affected by osteoarthritis. This is the first forest plots. As I said, we are comparing reconstructed patients with conservatively treated ones, and the number of events shows that there is abnormality in the knees. So as the pooled odds ratio, it's 1.84, which means there is almost 2 times higher odds to develop an abnormal knee for the reconstructed patients. But the interval is wide, and it contains the value number 1. So this is not significant difference. The second result is Arthrometry. This measures the anterior translation of the tibia and comparing the injured and the normal extremity. Here we are comparing the mean differences of the joint laxity in millimeters. The pooled result shows that it favors reconstruction with a minus 2.44 mean difference, and this is a significant result because the interval doesn't contain value 0. The third one is the International Knee Documentation Committee score. This is an objective physician-reported grade of 7 items that measures symptoms and function, but it's really important to underline that this includes ligament examination and X-ray findings, which were the first 2 results. Here we can see that both of the studies favors reconstruction, and the odds ratio is 0.48, which means there is a 50% less chance to have an abnormal knee for the reconstructed patients, and the interval doesn't contain 1, so this is significant improvement for the reconstructed patients. And our last result is the Lysholm score, which is a patient-reported outcome. So this is a subjective result. This is a scale from 0 to 100, and we were comparing the mean differences. As we can see, the pooled mean difference is 2.88 with a wide range of interval that contains 0, so there is no significant improvement in the reconstructed group, as well as almost a 3-point difference on a scale to 100 means clinically, it's clinically not meaningful as well. So, summary of my results: radiology favors conservative treatment. Arthrometry has a significantly better results in the reconstructed group, as well as the IKDC examination grade and Lysholm score has a not significant difference favoring reconstruction, but this is clinically not meaningful. So, as a summary, the strength of this meta-analysis is that this is the first one in this topic. Therefore, this is the most comprehensive literature search available until today, and our findings and suggestions could serve as a recommendation for later studies and guidelines in the future. Naturally, there are limitations to our studies. There were only a few studies and really different outcomes, so it was a hard time to merge these together. There was poor data reporting in the studies. We had mostly observational studies and only one RCT, as well ACL reconstruction techniques are heterogeneous. As a conclusion, we can say that our results support that conservative treatment could also be an option for isolated ACL ruptured patients in the general population, but further good quality RCTs are needed to address this question. Implication for practice is that we should consider conservative treatment as a primary option for this specific subgroup of ACL injured patients. And for researchers, RCTs are needed with standardized research protocols and outcomes, as well as studied with more specific subgroups like more active patients. For example, elite athletes would be good because they have a higher stress on their knees, where the higher stability means better function and could lower the risk of osteoarthritis. My second topic is about lateral extra-articular tenodesis. As I said, reconstruction is the gold standard, which has a good to excellent outcome. However, 1/4 of the patients has residual instability, and this lateral extra-articular tenodesis is an extra procedure that could reduce the laxity of the reconstructed knee. And we are trying to find out if this is superior to reconstruction alone. So we are investigating ACL reconstructed patients with LAT, compare them to reconstruction alone. We have made a preliminary research. We are expecting about 2,700 articles in this topic. So this is where I am after 6 months in this PhD program. Thank you for your attention, and my motto is that only time I set the bar low is for limbo.
Congratulations, Robbie. Of course, I know all the projects in the group, but actually I'm thinking, you told yourself that for the implication for research, you would suggest to investigate standardized better outcomes. Yes. I was thinking a lot lately about this core system in orthopedics, and of course, if you treat the patient, you treat the knee, it almost doesn't matter what do you use. Of course, some of them will lead to a better movement function score of the knee earlier. The other intervention will lead later, but anyway, the long term most probably will lead to the same result. Of course, if you are checking the odds of, for example, osteoarthritis, that's a diatom variable, diatom outcome of it. It's the most standardized. But if you are saying that you need more standardized outcomes, do you have anything specific? What would you suggest how to make a good outcome for the knee, for example?
Thank you for your questions. Actually, we wrote this because there are like 30 outcomes that is used worldwide for researches, and there is no protocol which one to use. Everyone uses an outcome which their center favors, and that's why it's really hard to compare these researches.
What do you think about the sensitivity of the Lysholm score, because you have used it?
Yes, so as I said, the Lysholm score is a patient-reported outcomes, so it really depends on how the patient feels about this whole reconstruction. But this is widely used and quite with acceptable outcomes and sensitivity. So and widely used. So this is a good score to measure the subjective outcome.